Thank you very much. Congratulations to the Bhopal Menopause Society for hosting such a wonderful conference. And, I don't see Dr. Srivastav and Dr. Khare. I saw her in the morning. So congratulations to them and the entire team. And of course, wonderful to see so many familiar faces, including the team from Orissa, Dr. Hara Patnaik, your past IMS president. So I'm going to be speaking on unmasking perimenopause, bringing clarity to the silent transition. So menopause in India, everybody knows, around 47.5 years age, and Indian women are likely to spend almost 23 to 24 years post-menopause, and nearly 103 million women are today suffering from the menopausal issues. So we know the stages of menopause, starting right from the premenopause to the perimenopause, to the menopause, and finally the post-menopausal stage, which is actually the more dreaded stage. So when you're looking at that division, early perimenopause, then the perimenopause, we should start preparing our women so that they can reach that menopausal age with a much more greater confidence and empowerment, so that they can handle the problems of the post-menopause much more better. The Lancet Series 2024 on menopause mentioned that it is a life stage for half the world's population, but experiences vary hugely. And this series particularly argues that there should be a new approach for supporting and empowering women transitioning through the life stage. So 2 to 4% also have the premature ovarian insufficiency before the age of 40 years, and we know what we have to do for them. But 8 to 10% experience those typical perimenopausal symptoms at the age of 40, 44, 45, and 1 billion, as I said earlier, are postmenopausal. So 84% of women, if you're looking at the menopausal epidemiology, say that it interferes with their life, but there are 12 to 15% who find it extremely debilitating. And nearly 40% say, kabhi kisi se baat hi nahi kiya. So only 1 in 5 women gets a referral to a menopausal specialist, provided they approach the correct person. So the signs and symptoms, I think this August audience knows, but we know that the CNS gets affected, particularly, as Dr. Medgood said very earlier, sleep disturbances, cognitive functions, mood disturbances, vasomotor symptoms, which affect the younger women more so than the little older women. The musculoskeletal symptoms, particularly the joint aches, backaches, and what is worrisome is the loss of the muscle mass and the loss of the bone mass, and the genitourinary, one of the commonest yet one of the most neglected. The vulvovaginal atrophy, the dyspareunia, the sexual dysfunction, the incontinence problems, and the forever trips to the loo for the urinary frequency. So these symptoms vary right from the early perimenopause to the postmenopause. So whether they are menstrual, whether they are vasomotor, whether they are the sleep disturbances, whether they are vaginal atrophy, or whether they are the bone health, you see a gradual problem occurring, and there is a silent progression to the problem, and therefore we have to be very, very alert. So how exactly does this happen? Again, all of you all know this, but what is worrisome is when the progesterone levels start fluctuating and becoming low. That's where the periods go haywire. There is trouble sleeping, there is a typical mood swings, anxiety, and the PMS. But the low estradiol is one which contributes to the missing of the periods, the hot flashes, the vaginal dryness, the irregular cycles, the hair thinning, which is very bothersome to women, and the dry and the elastic skin, and the recurrent UTIs. And the low testosterone, we always know that that is the one which causes the brain fog, the low libido, the fatigue, the depression, and the difficulty in losing weight, and also contributes to the dry skin. So obviously you're all familiar with this menopause 6 questions questionnaire. Any changes in your periods? Do you have any hot flushes? Is there any pain in your, the vagina, any dryness, any bladder symptoms? How's the sleep? How's the mood? So when you answer these 6 questions, the patient will tell you something, and then you know, okay, this is the way I want to go forward and treat her. So perimenopausal problems do affect the quality of life. If you're looking at the work patterns, working women particularly, 40 to 45% of them say it does affect their quality of life. They're less confident. 47% say they sometimes have to take a sick leave 1 or 2 days, when they feel really very, very low. Then the social problems, avoidance, going out late night parties or meeting friends, or 23% of them also feel, I'd rather be on my own. And then the sexual problems, you will have this, you really have to ask women to get that question out. But 51% say that it has affected their sex lives definitely, and probably they haven't had sex for several months or years. So this is a prime stage for management, and I'm sure as IMS and as women, we are responsible for addressing these particular issues. Try to find out what are the early symptoms. We want to prevent the long-term risk. Early discussion and counseling women, informed decisions and treatment options, and addressing the underlying conditions, because many a times this is the time when the comorbidities get absolutely unmasked, and then help them to get the appropriate treatment. And of course, we have to support our women. So the natural ways, obviously Dr. Medgood said, wonderful lifestyle changes. Do all that she has advised, and advise your patients that supplements, the calciums, vitamin Ds, all the micronutrients, the vitamins, the evening primrose oils, the hormone therapy as and when indicated, whether it's estrogen alone or whether it's a combination, depending upon whether there is a uterus or whether she's already had a surgery, the non-hormonal medications, which will include the antidepressants, the clonidines, the gabapentines, sleep medications, and of course calcitonin and minoxidil, and lifestyle changes. I won't talk about that because she's already very beautifully talked about that. So when do you consider non-HRT? Now the word actually uses MHT, but when do you actually, when should it be considered for the perimenopausal stage, and why? One is because it empowers women with their lifestyle control, and if you're giving them some kind of supplements, you can tailor it individually. Fewer side effects if you're doing the non-HRT. There is no hormone related risk, and the benefits are, of course, it is suitable. If it affects you, if it helps you, and you're still doing your lifestyle changes, why not? Please do it. And it gives a holistic mind-body balance. Many times women say, I don't want any medications at all. I just want to do everything naturally. Well, let them do it naturally, but when there is a need, we have to help them with those supplements. And when and where do you consider MHT? Obviously, women who've got asymptomatic fibroids, or women who need some kind of hormone, you decide whether you want to give it, what are the pros and cons. What about endometriosis? They've had their ovaries removed, or they've had a lot of ablative surgeries done. In those cases, counsel them and do give them MHT, the estrogen therapy, but do explain to them that small risk of recurrence of endometriosis. Cardiovascular problems, again, you can give it at the right time, because it can reduce the cardiovascular risk, provided you've propped it at the right time. Even hypertension, you decide, okay, you don't give an oral one, you give a non-oral one. So you decide how you want to give it. What about women with a high BMI? The epidemic of obesity is rising. There again, you probably want to give something which is non-oral. Women above 60 also have hot flushes. Not so common, but they also complain of menopausal symptoms. But in these cases, you don't always want to initiate MHT, because you consider some alternatives. Again, if the symptoms are very severe, you can give it for a very, very short period of time. But one good opportunity for screening women at all possible ages, because this is the right time to do that. So individualizing MHT is the key recommendation from all the guidelines, be it POI, be it between 40 to 50 years when the benefits exceed the risk, between 50 to 60 years when the benefits exceed the risk, and above 60 that the risks are far more. So then what are the non-HRT options? Lifestyle changes, as beautifully dealt with earlier, natural remedies, black cohosh, evening primrose oil, isoflavones, ashwagandha, and there are other medications like gabapentin, clonidine, vaginal moisturizers, and the SSRIs. So when you're talking about the non-hormonal treatments, what you must remember is basically you must have something where there are adaptogens. Adaptogens are basically something derived from the plant or the herb or from the mushrooms, where they are able to help women or their bodies to cope with the stress, phytoestrogens, micronutrients, minerals, along with lifestyle management. So, is there something available? Let's have a look at it. There are proven actions of herbs for perimenopausal management. Though we as allopaths always question what is the proof, there are trials, there aren't huge RCTs, but there are some observational studies, there are some RCTs, and this has been proven time immemorial. Some of these things have been used, and the main principle is they bind to the GABA receptors in the brain, they help to reduce the perspiration, and therefore they improve the hot flushes. Something like sage, something which is officially called as saliva officinalis. Again, there are passion fruit, passiflora, or there is the black cohosh, or there is the red clover, or even the soya, ginseng. All these in some way do mimic the estrogenic effect. They do inhibit the angiogenesis, and they do give that estrogenic effect which makes the women feel good. So let's look at every particular herb. Black cohosh, major content, whatever the major contents are, they do help definitely in improving the hot flushes, the night sweats, and the scientific name, of course, is Cymifuga racemosa. And what does it really do? It has a direct estrogenic activity. It acts as a SERM and binds with the serotonin receptor. And there are some studies, again, if you look at the number of studies, they're not more than 1 year or 1.5 years, and they've got smaller sample sizes, but yet they have shown a definite benefit in the reason that they've been given, particularly the hot flushes. They have shown a 60 to 64% reduction in the vasomotor symptoms. So there are studies which are saying that, and as I said before, these are clinical trial summary data which have been published in journals, not just word of mouth. Again, sage, which is Salvia officinalis. Here again, what it does, it acts through the neurosystem, neurological pathways, and therefore it affects the thermoregulation and helps in the hot flushes. And because of the anti-dopaminergic activity, the woman tends to feel good. There's a reduction of the depression phase, and the content, the phytoestrogens, help in doing all this. Again, here there is the clinical trial summary data. I won't go through all of it, but different combinations, 100 milligrams, 200 milligrams, over a period of 8 weeks, 10 weeks, all these have been shown to have a significant reduction in the side effects of the perimenopausal, the symptoms that happen. Ashwagandha, I think ashwagandha is very, very popular. Even when you talk of ashwagandha, you know that it puts you off to sleep. It is an adaptogen. And basically what it does is, it raises the estradiol levels through an antioxidant effect and has a calming effect. And the very name ashwagandha means trying to put you off to sleep in a much more better way. So a lot of these products are containing the ashwagandha. Again, small amount of RCTs. There's also a double-blind randomized trial, and these have shown significant reduction in the total MRS score, improvement in the psychological and the somatovegetative as well as the urogenital domains. And the combined treatment, when you're combining 3 or 4 drugs together, the ashwagandha churna as it's called, this definitely helps in the somatic and the psychological complaints. So isoflavones, I think we know a lot more about isoflavones because they've been there for a long amount of time, particularly the soya isoflavones, the diazine, and these, what they basically do is they are again SERMs. They help in reducing the osteoclastic action, improving the osteoblastic action, stimulating the estrogen receptors, and improve menopausal symptoms and a general human health status. So again, there are many more studies of the isoflavones, almost 19 RCTs, and they have significantly reduced hot flashes as well as the overall symptomatology which is related to the perimenopausal thing. Now, when you're looking at the risks of the cardiovascular problems and the bone loss increases during perimenopause, we know that during the perimenopausal phase, this is a time when the woman should be alert. You must know how to reduce your CVD risk. At menopause, the period stops, and we are waiting for 9 to 12 months before the periods actually completely stop and you declare as menopausal. But after that, the bone osteoclastic action is very, very strong, and there can be heart issues which also come in, atrial fibrillations, and these again, since women are spending a lot more time, we know that the cardiovascular problems are also very, very important. So here again, the estrogen deficiency is very apparent, not only the osteoporosis but also the cardiovascular problems, and therefore this is one time when we have to alert all our women. Now, the question that you would ask is, why is isoflavones a preferred choice for menopause and perimenopause? One is because of minimal side effects. It improves the cardiovascular health. It reduces the bone loss. In fact, it improves the BMD by contributing to the osteoblastic action. And there have been meta-analysis of almost 23 to 24 studies which have clearly said that the isoflavones are not only improving this, but also improving the lipid profile, thereby the cardiovascular health. So these are some of the studies which are there with the ashwagandha, with the sage, with the soya isoflavones, and they are known to improve the problems. Now, along with this, if you're combining it with micronutrients and essential vitamins like the B1, B2, the pantothenic acid, B6, and the entire lot, you know that it supports the heart health, it gives amount of energy, it supports the reduction of the vaginal dryness, improves the vasomotor symptoms, reduces the night sweats, and overall feeling of well-being. And the vitamin D and the vitamin C definitely improves the immunity, and they are cardioprotective and promotes the bone health. Essential minerals, again, if you're adding, we never realize, but the tiny micronutrients and the elemental magnesium, calcium, iron, manganese, copper, selenium, iodine, all these, in value we say, oh, they are so small, but they improve when they're all put together. They reduce the risk of osteoporosis, they reduce the vaginal dryness, they maintain optimal hemoglobin levels with that little bit of elemental iron, they act as antioxidants, cramps are reduced, the production of GABA is reduced, and very, very importantly, the mental health, the memory is important. And if you have an optimal chromium level, it also helps in balancing the blood sugars. So overall, if you have a preparation which has got all these together, the vitamins, minerals, and the herbal products, don't you think that's a good alternative? If a woman, of course, needs MHT, well, you have to give it. But if one size, never fits all, you have to decide, tailor the treatment to the woman's choice. There are women who want MHT, who need it, and who absolutely will benefit. But there are women who you feel, okay, the MHT is not required, they're good, their lifestyle changes are good. Consider the non-MHT or the non-HRT regimens, and the women are happy. Rather than telling them not to take anything, at least take these things which are going to be helpful. And even along with MHT, one can give the non-MHT regimes, because these are all from the herbal kingdom. So tailor the treatment to a woman's choice, her needs, and her comorbidities, because friends, remember, one size does not fit all. And with this, I end my talk, and thank you very much. But I just like to say that, 20 years ago, there was such a scare of MHT, and people wouldn't prescribe. They would always say, scoff at any allopathic medication. But today we realize that we are at this juncture where we've got everything available. We can look at this and we can prescribe confidently to the patients. But when we tell them, ask them always to come for a follow-up, see how they feel, use your questionnaires to find out what is the quality of life improvement, and help them to improve their status and get them more empowered. Thank you very much.